No, slideshow.
There you go.
There
Perfect.
you go.
All right.
Yay!
Yeah. All right.
Trying to do its own thing.
All right. Good evening, everyone. Thank you so much for joining. Today is June 20th, 2023, and we are excited to welcome you to the Behavioral Health Workforce Education and Training Interprofessional Integrated Health Education Series. This program is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, and our grant numbers are listed for your review. Just a brief overview of tonight's agenda. I'm Dr. Katherine Brown. I'm serving as your moderator. I'm an assistant professor in the Department of Family and Community Medicine and director of the National Center for Medical Education Development and Research at Meharry Medical College. We will have a welcome tonight by Natasha D. Yokley, an introduction of our presenter by Dr. Frida H. Outlaw, and then you will have tonight's presenter, Dr. Howard Burley. As a gentle reminder, please keep your microphones on mute during the presentation. We do invite you to connect with us via the chat box for questions and comments during the presentation. At this time, let's give a virtual introduction. Please share your name, organization, city, and state in the chat box. Let's connect on social media. Please follow us on Twitter at PCTCOP and use our hashtag PCTCOP. We invite you to share your Twitter handle in the chat box and we will be sure to follow you. Save the date. Remember, tonight's presentation is part of the monthly Behavioral Health Workforce Education and Training Interprofessional Integrated Health Education Series. Our lecture series will return in August 2023. For more information, we have listed all of our websites for your review. We would like you to meet the team, Dr. Patricia Matthews-Juarez. You've already met me. Our psychiatry team. Our team at the Family and Community Medicine Department. And Miss Natasha Yokley, Mr. Ross Fleming III, and Miss Veronica Burns. And at this time, I'm excited to introduce Natasha Yokley. Welcome, Natasha.
Good evening, everyone. Good evening. At this time, I would like to welcome our providers, residents, our AHEC scholars, guests, and other health professionals to the Behavioral Health Workforce Education and Training Program at Meharry Medical College in the School of Medicine. The purpose of the BHWET program is to increase and expand the number of highly skilled, culturally competent behavioral health practitioners to provide behavioral health services in primary care settings to the vulnerable populations living in rural and medically underserved communities across the state of Tennessee and nationwide. The BHWET program is an interprofessional and collaborative partnership between the residency training programs in the Department of Psychiatry and Behavioral Sciences and Family and Community Medicine. At this time, I would like to introduce Dr. Frida Outlaw, who will introduce our guest speaker for the evening. Dr. Outlaw.
Thank you, Natasha. It is my pleasure to introduce my colleague and my friend, and at once upon a time when we worked together, my partner in crime down at the Tennessee State Department of Mental Health and Substance Abuse. Dr. Howard L. Burley, MD, is the Tennessee Department of Mental Health and Substance Abuse Services Chief Clinical Director. He previously served as the Director of Psychiatric Services for Cumberland Heights Treatment Center. Before coming to the department, Dr. Burley was Vice President of Magellan Behavioral Health of Tennessee. Boy, we're going way back with some of these, Dr. Burley. Dr. Burley is certified in psychiatry and addiction psychiatry by the American Board of Psychiatry. He holds a BS from Howard University and a medical degree from Meharry Medical College. He is currently a board member for the Metropolitan Nashville Hospital Authority. Other previous positions held include Director of Mental Health Services for Corrections Corporation of America, Medical Director of Residential Dual Treatment Services and Outpatient Services, Cumberland Heights Alcohol and Drug Treatment Services, the Metro Nashville Health Department Downtown Clinic, and Alcohol and Drug Abuse Services at Meharry Medical College. His expertise is in managed care, clinical psychiatry, and co-occurring disorders, which SAMHSA likes to call mental health and substance abuse. It is my pleasure, and I can really vouch to say, if you have a managed care issue or a co-occurring disorder issue, Dr. Burley is the man. So I am going to turn the mic over to Dr. Burley so you can partake of his expertise.
Good evening, everybody. As Dr. Outlaw said, I'm Dr. Howard Burley, and it's my pleasure to be here this evening. I just wanted to take an opportunity tonight to talk a little bit about substance use and abuse and how its impact on the brain can actually set people up to become addicted. For years, we talked about substance abuse being a flaw in character, and it's taken generations before we've gotten the brain chemistry down so that we can account for the behaviors that we see. And I'm hopeful tonight I'll be able to share some of that with you so that you can see how the drug's impact on the brain accounts for behaviors. I want to talk a little bit about the learning objectives. I want to go over the whole concept of rewards, review the mesolimbic pathway, which has been known for years as the reward pathway. I want to talk about the neurotransmitter system that mediates and the reinforcement of drug and alcohol abuse. And finally, I'd like to describe some of the risk factors for substance use and abuse in the progression to addiction. First, I'd like to start off with a definition of addiction / substance use disorder. We typically go with the DSM-5 TR definition in terms of the characteristics that make you eligible for a diagnosis of a substance use disorder. And just looking at those, I'd like to start off with the number one driver of substance use and abuse leading into addiction is the craving. It sets a person up to continue to use substances despite adverse consequences, and it leads to tolerance, which means that you have to take more of a substance to get the same effect. And we'll look at a lot of that as we talk about the brain chemistry that's impacted by substance use. You continue to use substances even when it's to put yourself in danger. A person's willing to give up their social, occupational, and recreational activities. I can't tell you how many people I see that become their number one complaint when they come into treatment is isolation, loss of employment, and the fact that they just don't do any of the things that they used to do. These are pretty common denominators for people who've developed a substance use disorder, and that they even continue to use when it impacts relationships. Substance use is one of the main contributors to divorce, and the person continues to use despite the impact on home, work, school, and this is kind of the spiraling down that we'll talk about as a person moves from use into addiction. In order to understand addiction, because it's something that really defies sort of common sense, because if all those things were happening to a person that we just saw on the previous slide, it seems like a person would just go ahead and recognize, I need to quit doing this. But by the time those characteristics come about, their use is typically out of control. And when we want to understand addiction, we need to learn, we need to remember that all behavior is typically determined by what happens in the brain, that the brain is chemical in its nature, and the changes in brain chemistry account for the behaviors that we see. And we need to understand the brain's reward system to see how drugs and alcohol change that system. Let's try the next slide. I wanted to start off by just talking about the whole concept of what is a reward, because we talk about the dopamine system or the reward system. So just what is this reward that we're talking about? And the answer to that question is, it's a feeling of positive value. It's a feeling of pleasure. And it's this feeling of pleasure that reinforces the behavior of seeking that pleasure over and over again. The other thing, the rewards can be satisfy a state of need as well. If we look at the next slide, we'll see that the basic natural rewards, food, water, sex, and nurturing, go back to the beginning of time. It's the concept that when we are hungry and we eat, that satiation of food drives the desire to do it again. When we're thirsty and we drink, we know what to do when that's happening again. And then the nurturing and the use of sex are both pleasure driving forces that drive the reward system. I wanted to talk a little bit now just about the gross anatomy of the reward pathway. And the main thing to remember when we're talking about addiction, no matter what drug you're talking about or alcohol, it's driven by dopamine. Dopamine is the key to addiction, either directly or indirectly. So I want to look at the pathway of just how this operates within the average brain. So typically, when we talk about positive stimuli or rewards, they impact the ventral tegmental area of the brain. And this is sort of the storehouse of dopamine within the brain. And what happens is when the brain experiences that positive impulse, it releases dopamine into a pathway along the brain. That pathway typically runs from the amygdala to the nucleus accumbens. It goes through another set of pathways up into the frontal cortex. And each one of these steps along the way carries its own impact on a person's behavior. When we start off and that initial impulse triggers that ventral tegmental area, what happens is you get the first place on the track is the extended amygdala. And it's related to emotions. It's also related to fear and anger. And when we talk about, well, let me do the part first. Let me go through the direct path, and then I'll come back and make some comments about some negative aspects of this. Typically, when that dopamine goes through the amygdala, there's a feeling of euphoria and joy, pleasure that hits the amygdala. And the amygdala, it takes that experience and it sends it over to the hippocampus. And the hippocampus is extremely important in this whole process of addiction because the hippocampus stores that memory from that positive response. And this is how we wind up talking about triggers as people get deeper into recovery, because those memories that come from that positive experience get stored there and they're housed there indefinitely. So even when people go into recovery, those feelings of euphoria that they experienced when they first engaged in the use of alcohol and drugs is something that they still think they can recapture from those memories that are stored in their brains. The nucleus accumbens is sort of the powerhouse of the main site of dopamine release and function within the brain. It's also been titled the pleasure center. It's the area where those positive feelings or that euphoria housed and typically have its most effect. In the beginning, we were showing the basic rewards of thirst and water and sex. And when they first started doing brain mapping, one of the things that they did was measure the activity that went on in the nucleus accumbens under stimulation. And what they found was that the largest triggers that created the highest volume of dopamine were the things that were related to basic survival things, such as obtaining water, obtaining food, procreating through sex, the nurturing of others, that this generated the most dopamine in that area. The other thing that they learned as they moved a little bit deeper in the studies, when we started looking at mice studies regarding around this area of the brain, is that whenever they set up a situation where mice could stimulate this area of the brain by pressing a trigger, that they did that indefinitely. The unique thing about this situation was that the mice would trigger it to the point of death, that none of the mice survived. They kept triggering the stimulation at the exclusion of food, water, and everything else that was needed to survival until they ultimately died. And then that's how the nucleus accumbens became known as sort of this central bank of dopamine storage. So the way that this typically works is you get a trigger from the ventral tegmental area, the impulse goes out, it goes through the amygdala, it generates a feeling of well-being, euphoria. It takes that, translates it over to the hippocampus, and then it translates it down into the nucleus accumbens for the release of dopamine. It also has impacts on the other areas of the brain, including the frontal cortex, which is involved in planning, logic, and judgment, and it influences the choices that a person makes based on its prolonged exposure to dopamine. And we'll talk about that a little bit more in a couple of slides down the road. Okay, there you go. I just wanted to show a small version of the same thing that we just looked at, and that's the ventral tegmental area to the nucleus accumbens pathway that is activated by all illicit drugs and alcohol, once again emphasizing the role of dopamine in the development of an addiction. And we also want to highlight again that it was not only important in the use of drug and alcohol, but it was essential in life's functions such as eating, drinking, sleeping, and sex. All right. This slide is just to sort of give you an idea and illustrate what happens with dopamine release. And as we move along, we'll talk a little bit about how this is impacted by individual drugs. But just to give you a concept of what basically happens, dopamine, there's a stimulation, dopamine is released into the synaptic cleft, and then it goes and attaches to the receptor and generates the feeling of pleasure. And this is the way it works in our normal day life with birthdays, weddings, anniversaries, just anything that you can think of that generates a feeling of joy in people is associated with the release of dopamine in the process of that positive feeling. Okay. All right, this section here is just a cross section of the brain that I wanted to note that there are certain triggers on this whole process of dopamine release. Just as dopamine can be released with a stimulation, there are checks and balances to the effects of it. Say, for example, when there's more dopamine released, there's an inhibitory neurotransmitter in the brain called GABA, which acts to sort of moderate that response and keep things under control. One of the co-conspirators with dopamine in this process is glutamine. And stimulation of dopamine also stimulates the release of glutamine, which are both excitatory impulses. So it's you have your GABA trying to mediate these responses, with the whole idea being that your brain wants to keep everything in balance. And this is the way that it's designed to work in a natural state, which is impacted when we start using alcohol and other drugs. Okay. This is just sort of an illustration of what I was talking about in terms of the balance that the body tries to maintain. You have glutamine and dopamine, which are activating neurotransmitters, and they lead to impulsivity, mania, substance use. I think very often you'll see in certain drugs when they're, say, for stimulants, which we'll talk about, it leads to sometimes psychosis. And this is due to the high flux of dopamine and glutamine being flushed into the receptors within the brain. And then you have the GABA on the other side, trying to maintain a euthymic state, help a person to stop their use when they're starting to have some of these adverse effects in their life. And it also tries to help maintain the judgment. So this is kind of a constant seesaw, tug of war that goes on within a person's brain in terms of trying to maintain some type of balance. All right, this slide, I just wanted to talk a little bit about some of the individual drugs and their impact on dopamine and why some drugs are more prone to lead to addiction faster than others. I think if we want, I want to start off with probably one of the most addictive drugs, which is amphetamines. And amphetamines are particularly addictive because if we reflect back to that slide that we saw about dopamine, and here we get, and once again, we can see it in this slide here with the dopamine being released into the receptor sites, is that typically what happens with dopamine is that once it's released into a receptor, it goes to that receptor, it does its thing, transmits its message, gets broken down, and then gets reabsorbed back into the vesicle again to be resynthesized and to kind of continue this check and balance system. When we talk about drug and alcohol use, we talk about them hijacking this pathway. Because this is where we really start to develop and see how the use of certain drugs reinforces the behavior of continued use despite any adverse occurrences that are happening in a person's life. So if we look at specifically amphetamines, what happens is that you get the release of dopamine into those receptors. But one of the things that amphetamines do is they block the reabsorption of dopamine back into the receptor. So what happens is those receptors started being bombarded with dopamine. And the second thing that amphetamines do that's a little different from other drugs is it also stimulates the release of dopamine. So you have an enhanced release of dopamine coupled by an inability to reabsorb it so that the receptors become saturated with dopamine. I think if you think back to that other slide where we saw the dopamine coming out of the vesicle, coming to the receptor, it was like those receptors are being bombarded with dopamine to a point of saturation. One of the things that happens with this is that you start to lose receptors. You burn them out. And where this shows up in everyday life. We see in relating back to those characteristics of addiction is those things, those simple things that used to help you derive pleasure are no longer impacted because the system has been overwhelmed by the volume and intensity of the dopamine that's being produced from the stimulation of particular case amphetamines. But this is why you see people become more isolated. This is how they lose interest, because those things that hobbies, friends, things that used to stimulate that process normally for them to experience some joy and pleasure, it doesn't happen for them anymore. The other thing that we also see with that is that there is tolerance built to that effect, so that they need more and more dopamine to create that same effect that they were originally getting. And we'll talk about tolerance a little bit further down the line. But this is the process that goes on that drives the person, just like in the mice back in the beginning of time, to continue to use no matter what's happening adversely in their life. When we talk about cocaine, which is also a stimulant, does much of the same thing as amphetamine, but does not create that same constant flow of dopamine onto the receptors. But it also blocks the reabsorption of dopamine, once again, saturating the receptors and driving that behavioral force to continue to use drugs. Now, when we showed that cross-section slide, we talked a little bit about GABA and the impact of GABA is in its role as trying to help balance off this system. I'll talk a little bit about GABA in conjunction with alcohol, because alcohol is a GABA agonist. And what happens with that is that it stimulates activation of GABA receptors. And where we see this in practical life, because I like to try to account for people's behavior about what's happening in their brains. And if you think about it, if you have a person who is not an alcoholic, who is a little tense, a little anxious about a situation they're in, a social setting that they have to go to, they might go ahead and have a cocktail. They go ahead and have a drink. And what happens is that alcohol enhances that GABA agonist. It helps slow down neuronal activity in the person's brain. And this is why you see people become more relaxed, disinhibited, because they're getting this activation of GABA that helps them feel more comfortable and relaxed. The only problem with this is as we get into chronic use, the GABA actually becomes depleted. And the loss of those inhibitory functions from GABA result in the things that we see when a person becomes actually an alcoholic. When they go into withdrawal there, since there's not that balance in place, there becomes an overstimulation. And as they proceed into that pathway, what happens, a person goes from feeling relaxed when they drink to a point where they experience blackouts when they drink. And then it progresses even further to where there's overstimulation within the system, that they become at risk for increased neuronal activity in the brain, which ultimately can lead to things like withdrawal seizures and delirium. So this is kind of the process that we see. These function by opening up ion channels within the brain, and other drugs that act like alcohol on the brain include PCP and ketamine. I want to also reemphasize that point that all these substances, while their mechanisms of action may be slightly different, they all still work to increase that release of dopamine, once again, refueling that behavior to continue to use to recreate those feelings that they once experienced. I think if you work with people who have addictions, one of the things that you'll hear them talk about is trying to chase the high. And what has happened is that as their tolerance has been increased and their receptor numbers have decreased, they can't get the same effects that they used to get from their use of a substance. And this is where that shows up here. This is how they drives for greater use and actually can lead a person into overdose. The other set of drugs that I want to talk about were those who not only work by releasing dopamine directly, but also act within specific receptors in the brain. Opioids tend to act at the endorphin receptors within the brain. And then we have the cannabinoid and nicotine receptors that are influenced by those particular drugs. And so you have the dual receptor action as well as the pleasure release of dopamine into the system as well. So that's just kind of briefly looking at all the substances and sort of seeing how they tie together in terms of this effect on dopamine and driving the behavior. The other thing that I want to mention too about this is that it's very rarely that you see an individual that's addicted to only one substance. Most people are engaged, if not addicted to multiple substances. They may have an addiction to one. Say, for example, if they use a stimulant, they may use alcohol as a way of coming down from that experience. And this ties back into one of the things that we talk to people in treatment about, because very often a person will come into treatment and say that, I was addicted to cocaine, or I was addicted to meth. I never really had a problem with alcohol, and I don't see why I can't use that again. But this whole interconnectivity between substances is how we try to explain to them that the use of one substance can not only lead to the abuse of that new substance, but can lead to relapse back into the old substance. Thinking back again to the slides that we saw earlier, when we talked about that whole process of stimulation from the ventral tegmental area and that feeding into the amygdala and back into the hippocampus. This is where it comes into play because the hippocampus still has those memories stored from those initial experiences a person had with drugs and alcohol. So while a person may not have a dependence on a second drug, what happens is it can stimulate that hippocampus to bring memories back of the drug of their choice. And this is one of the things that people deal with in recovery when we talk about it in terms of them having triggers and having to avoid certain places and people early in their recovery periods, because it sets them up for this whole experience of a relapse secondary to these previous memories coming to the forefront and once again stimulating cravings. When we see people in treatment very often, we talk about cravings as kind of their measure of how they're doing in treatment, how have they been away from the drug long enough that they're starting to be at a point where they can exert some control over their behavior. It's not necessarily a fact that they're gaining their willpower to be able to stop their use, but what they're being able to do is break the cycle enough to where they can utilize other tools available to them so they can interrupt their pattern of substance use and abuse. Okay, we can go on to the next slide. This slide, I just wanted to talk a little bit about what happens to the brain after long-term chronic use of a substance. We start off looking at that whole ventral tegmental area in the reward pathway. And the first thing I like to do is just kind of walk through what happens when a person who's not addicted engages in the use of substances. We look down at the amygdala hippocampus reactions, and what we see is we still get stimulation of that positive feeling from the amygdala going into the memory of the hippocampus. But since this brain is not addicted, the person is able to stop. And that's the point that we want to make there in the non-addicted brain. Their motivation to go out and obtain that drug, which happens through the prefrontal cortex. This is where those impulses to go out and drug seek, go out to buy, obtain, use whatever substance it is they're addicted to is generated. So the prefrontal cortex is sort of the motivating factor to make them go out and obtain the substance that they were abusing. The other thing that happens in the prefrontal cortex is there is continued utilization of impulse control. The person can make conscious decisions that I've had enough, I don't need to engage in this anymore, it's time for me to stop. Once again, coming back to that emphasis on the word stop. So what happens when we start looking at the addicted brain? We get the same thing that happens with the stimulation of the amygdala, the hippocampus. But what we will see is that those stored memories and previous experiences are much more intense. If we compare the arrow going up to the VTA in the addicted brain to that in the non-addicted brain. So that driving force is much stronger there. And if we look up at what happens in our prefrontal cortex, what we see is that loss of impulse control is not very good at all. And for illustration purposes, we look at what's happening in non-addicted brains versus the addicted brain. And finally, that motivation, in this case, it's not the motivation to not use, it's the motivation to go out there and obtain the substance of abuse. It's extremely high. And this is why people continue to engage in the behaviors that led to what we described as making them meet the criteria for developing a substance use disorder. Now, one of the things that people ask a lot is about, what if I stop using? How long does it take for my brain to get back to normal? How long does it take for the pathways to get back to where they're functioning like they appropriately should? And the answer to that is years, because depending on which substance you're using, you not only engage in destruction of brain receptors, brain tissue. We see this in people who develop dementia with alcohol. We see this in people who develop refractory psychosis and meth and cocaine users or hallucinogen users. That you not only have the damage to the pathway itself, which can take years to try to improve or get near back to where it was functioning, but you also get direct damage to many of the structures that are surround them and that are involved in trying to maintain this balance. This is one of the reasons why we talk now is addiction being a chronic relapsing disease, because even though a person never has to necessarily relapse, there's a high probability, depending on circumstances, support systems, their engagement in other treatment resources, and a multitude of factors we'll touch on a little bit later that impacts their ability to maintain sobriety. Okay. This slide is one that just wants to talk about relapse. And when I was talking a few minutes ago, I talked about controls versus normal people versus using again. So in this slide where it says unexposed controls, it's talking about people who've never become dependent or addicted. And what happens is that with abstinence from the substance, the drive to use the substance tends to diminish. And there is a tendency to be less at risk for relapsing back into a pattern of drug use and abuse. But if we go back and look at, say, for example, a person who's had a significant history of addiction, and they go back and for whatever reason, attempt to engage in use again, it's much more likely, say, for example, if they attempt to use a drug in small amounts for a while, that they will reinstate that pattern of use, and it will return to being as severe as when it first started. One of the things we talk to people about is their inability to go back in time to when they first started using drugs. The thing that a lot of people with substance abuse issues think is, well, it's been 2 years, 3 years, 10 years since I've engaged in this use of this substance. But because of the things that we've talked about, the memory storage, the history of response and dopamine release, they quickly return to their pattern of use, despite how much time they may have placed in it. The other thing that is a key issue in the reinstatement of use are cues or triggers that we talk about. When we have people in substance abuse treatment, very often what we work with them about is dealing with their potential for relapse, avoiding certain places, because visual, auditory, tactile clues can all stimulate those memories of previous substance use and lead the person into relapse. Another key factor in stimulation of reinstatement of use is stress and anxiety. We know that stimulation of the hypothalamic pituitary axis by increased levels in stress tend to send off a need for a reward. And typically that reward for a person with a substance abuse history is the reinstatement of that drug use. So a person who had never become addicted has a significantly less chance of ever returning to substance use than a person who has been determined to be addicted and experiences all the characteristics that actually led to addiction. All right, do the next one. All righty. I wanted to put these up because we talk so much about the biology of addiction. And the factors that we put here are why some people become addicted in a short period of time, and other people go for extended periods of time in terms of their use before they actually experience the consequences that lead them to seek some type of treatment. So while the chemical factors are similar for the majority, it's the additional factors that may determine how soon a person is impacted by substance use. And one of the primary is the genetics. If I come from a family of substance users, both parents, the risk of a addictive disorder goes up with one parent, doubles with two parents, and moves on up even further with extended family members. The earlier the age of onset of use, the greater the risk of developing an addiction. We also need to, when we look at this, think about the fact that brains are in currently a state of development, so that the earlier the onset, the more likelihood of the risk of addiction. And one of the key treatment factors, key treatment focuses nowadays is on childhood trauma and its role in addiction, and its predisposition for making people more prone to not only engage in substance use, but to use substances to self-medicate the feelings and emotions that they experience from that trauma. When we started talking about this in the beginning and we talked about rewards, we were talking about a reward was something that takes away something that makes you feel adversely affects you. And that can be something like childhood trauma that hits the person emotionally. What they want to do is avoid that feeling and using that substance is the reward that helps them do that. We also know that people with learning disabilities such as ADD, ADHD, all are at increased risk for developing an addictive disorder. One of the things that I am frequently asked about parents, by parents, is about the use of stimulants in children and adolescents with ADD, ADHD. I think what the literature has taught us is that not treating a learning disability may be worse than the use of a stimulant drug to treat that disorder. First of all, individuals with ADD, ADHD tend to feel more normal with the use of that substance. And actually, studies have shown are less likely to abuse that substance. Whereas untreated disorders of childhood and adolescence make a person feel more isolated, can lead to more feelings of depression, feeling to being unaccepted, and could actually work in the opposite to reinforce substance use. And then we have the mental illnesses, which may predate the person's substance use. One of the struggles that we have nowadays is this chicken or the egg concept about, well, were they depressed before they started using substances? What age did they develop bipolar disorder? You know, if we suddenly decide that they were in their mid-40s before they got bipolar disorder, more than likely this is related to the substances. Then we also look at the presence of psychosis. Stimulants, cocaine can all induce psychoses, but as we look at the age of onset of use, we may be dealing with a person who was set up for their first episode of psychosis. But we still try to address making a determination about this because it may impact the speed in which we introduce medications for treatment of certain co-occurring depressive disorders. One of the things that I did want to mention though is, say for example, when we look at the stimulant drugs, cocaine or methamphetamine, I talked a little bit about its impact on dopamine and its release of dopamine. But one of the other things that we need to consider when talking about stimulant use and abuse is it also results in a decrease in the serotonin levels in the person's brain. And this is important for two reasons, because serotonin gives you that feeling of satiation and fullness. Is one of the things that helps you stop when you're engaging in a behavior where you see that you're going too far. It creates, say, we'll use food as an example. It's one of the things that's activated to give you that feeling of fullness. So that when you engage in the use of stimulants, cocaine, these substances, and you decrease that level of serotonin in your body, the thing that happens is that you become more prone to depression anyway. So in the end, the person's depression may be related to a natural deficit of serotonin, or it could be due to a substance use. And the same thing happens with the use of stimulants in terms of mood disorders. Once again, changes in the availability of these neurotransmitters can take a person whose symptoms might be mild and make them much more severe. But the presence of these all are additive risk factors for the ultimate development of an addiction. Okay, we can take a look next one. Okay, this slide is all about going from being a comfortable weekend abuser to the point of developing an addiction. We look at something we call the 3 C's of addiction. And the number one thing that we look at in terms of this, that we question patients about, is their ability to control their use. Most people that I see entering into treatment, this is one of the things that leads them to come in and seek treatment, because they say, I can't stop using on my own anymore. I might be able to stop for a few days, maybe even a couple of months. But once again, based on all those other factors that we talked about, once again, there's a loss of control. Compulsion. Compulsion is the drive to do something over and over again. This ties back into when we looked at the brain chemistry, and we talked about the behavior mechanism of continuing to use a substance despite adverse effects. There's something that this is one of the things as we talk about addiction and we list those symptoms that people have. This is why they're so common to all of those 20 million people in the country that share an addiction. It's that compulsion to go back and use that drug again or use that alcohol again. The compulsion is once again driven by that desire to produce that reward. And this is another one of the steps as we move from substance use and abuse to the whole idea of addiction and the consequences of addiction. Okay, chronicity. I talked a little bit earlier about the fact that we necessarily don't move in the treatment of an individual as looking at it as okay, you went to treatment, you did 28 days. If you have exceptional insurance, you did 90 days. You've been abstinent this whole time. You've started to regain some of the things that you lost secondary to your addiction. So now you should be able to kind of go out there on the path of recovery and lead a normal life. And that's when the chronicity comes in, because it's not that simple. A person may not relapse, and I always tell people that just because you may be in treatment with people who've been here 8, 9, 10 times, that doesn't mean that has to be you. But it also is dependent on the things that you do once you get out of the bubble of being in a treatment facility. One of the criteria that managed, since we were talking earlier about managed care and reviewing cases for managed care, when we talk about people being in substance abuse treatment, and I review it with an insurance company, one of the first things they ask me is, can you explain to me why this person has to be within a setting where they have to be monitored 24 hours a day? And that goes to the chronicity of their disorder because of the high potential for relapse. And that is that people need to regain all of the skills that they can in terms of coping, dealing with the triggers in their community, because most people don't get to leave treatment and go to a brand new world. They get put back into the same circumstances that they originated from. And if they don't have any idea about to manage those circumstances or have developed the skills to know how to reach out for help, use sponsorship, or engage in other forms of assisted treatment that may help them address this, it leads to the chronicity of their condition. And this kind of just walks through the steps that we talked about in terms of moving from abuse up into the world of dependence. We go through the social recreational use, the loss of both emotional control, the compulsion, the going out, drug seeking activities, the cravings, and the continued use despite adverse consequences. When you're confronting a person with an addiction, one of the things that you can't do is tell them what they can and can't do. What you can do is to try to talk to them about the experiences that they've had and bring up the behaviors that they've shown in their use in their continued use of a substance despite those. I saw a patient a few weeks ago who had actually said that he'd had at least 20 to 25 opiate overdoses in his life. That instead of it being a deterrent, being that close to death so many times, his reaction to that was, I keep Narcan all over my house and I make sure all my friends have Narcan when we use. But this just kind of shows you the mindset and the drive that many of these individuals may have in terms of addressing their substance use. Once again, chronicity, referring back to multiple use, we talked about. The other thing I'd like to mention about this is that relapse is possible after years of sobriety. And I see people coming into treatment very often who may have sobriety periods varying from 1 year to up to 20 years. And I think something that I see in people who've had substance abuse issues in the past is their desire to help other people with substance abuse issues going forward. So it's not unusual to have somebody who had suffered from a drug dependency in their past, who entered the substance abuse treatment field, has been working for patients, or if they're not formally in the field, are working, providing sponsorship, who start taking care of others more than themselves, and then fall into the trap where they stop doing all the coping skills that they had developed over the years and relapse once again after years of sobriety. Okay, this is just another way of illustrating that whole pattern of moving from preoccupation to tolerance. We go from using to binge intoxication to tolerance, and then into withdrawal. There's one thing I did want to say about withdrawal and potential for relapse. I like going back to that slide of the brain because it's a good illustration there. Because we talked about the amygdala and its hookup with the hippocampus. And it comes into play when we talk about the role of withdrawal. Because when people come into treatment, they are so afraid of going into withdrawal if they've ever experienced it before. That negative, just like those positive experiences get incorporated into your mind and into your hippocampus, that negative feeling of withdrawal is another factor that goes there. And I see people that will do anything to avoid the feelings of withdrawal. This is one of the main factors, if it's not handled properly, will lead to people leaving treatment AMA. Before we had the use of opiates like buprenorphine to help with detox, I thought it was near impossible to help a person detox off of methadone. Because if they had been on it for a number of years, it is so ingrained in their system that as they went through the withdrawal period, the physical feelings coupled with the cravings they experienced frequently led them to leaving treatment early. And it is just one of the things that you have to deal with in terms of getting a person stabilized enough to enter into community-based treatment services. This is the exact same thing as the other slide, but it's a little bit different because it illustrates the downward spiral. And I like this because we talk about people reaching a bottom, and this is kind of what this is. It shows that consequence after consequence, it may be a loss of job, it may be a loss of wife, it may be their increased isolation, the loss of friends, and they continue to engage in this pattern of use and abuse as they continue to move deeper into the consequences of their addiction. We try to intervene in people earlier as possible in this cycle because it allows for a greater sense of recovery. Because the one thing about continued substance use, we talk about it in terms of the brain, but it also has impact on the rest of your organs in your body, heart, lungs, kidneys. As you get more and more into this process, the more life-threatening complications you can experience in your addiction. So I wanted to talk a little bit about what is treatment. And treatment starts off with detoxification. If you can't get a person off of a substance, how can you get them into some type of recovery? We have moved more towards using outpatient-based detoxification with opiate users. It used to be at one time, if you talk to an emergency room about starting a person on Suboxone or buprenorphine, they would tell you were crazy. Because the idea is, I'm not going to do anything that's going to attract all these opiate abusing people to me when they start going into withdrawal. But what we've learned is that if you can capture that person when they're in a position where they're ready to end the treatment, the more likelihood that you're going to be able to get them into that treatment, because people go to the emergency room when they are in crisis. And that's whether it's opiate, benzodiazepines, alcohol. When they get scared, the ER is the place that they go for treatment. If they go there and they get an assessment and they find out, oh yeah, we can get you an appointment in a week or 2 weeks, so it might be several days. What happens is that person is usually under the heading of loss to follow up. Actually, the state and Vanderbilt and several other hospitals in the area have been looking at the possibility of doing induction with Suboxone for opiate addicts that present in the emergency room. And this is done in conjunction with community-based opioid providers. That might be through a formal mental health organization, or that might be through community buprenorphine providers. One of the things that used to be a barrier to this was it used to be you had to have the X waiver to prescribe buprenorphine, which meant that you were allowed to carry a certain number of patients under your care. As the opioid crisis has risen in this country, the decision was made to do away with X waiver licenses. So those no longer exist as of this year. So anybody that's licensed can provide buprenorphine treatment to substance abuse patients. So what we're doing now is trying to identify these providers in the community so that we can, if a person is not able to access a residential treatment program, that we can channel them over to some outpatient program that can maintain them and address their cravings. Because once again, the cravings, withdrawal, are the biggest triggers for relapse and continued substance use and abuse. We also know that treatment needs to be more individualized. You know, back in the, I don't want to go too far back, but we'll go back to the 2000s. Programs used to be, this is our program. We are a 28-day program. This is what we do. This is our course. These are our manuals. These are our books. This is what we do. And it's not based on that person's individual needs, which sometimes made that person feel different from his peers or her peers, and made it more difficult for them to engage in treatment. So what we've learned is that as we see people coming into treatment, and we're looking to do individualized assessments, because it's important to know if they have co-occurring mental health conditions. It's important to know if they've had a history of trauma. It's important to know if they've had PTSD. One of the other things that I've learned it's important to assess a person for is their history of military experience. Because what I've learned is vets have a whole different world of needs and things that need to be addressed in terms of getting them into an appropriate treatment plan for their substance use. And it also, we also want to point out the importance of supportive services. The more things that you can wrap around a person in terms of keeping them in a safe environment, increases their likelihood of success with their substance abuse treatment. Supportive services such as housing, access to medications, you know, despite all the things that are happening in terms of covering uninsured lives, there are still a number of people who don't have access to medications. We try to address that in Tennessee through the safety net program, but there's still an unmet need for people that can access their medications. Because if I have co-occurring depression, bipolar disorder, any of these conditions, and I can't access my medications, once again, that's going to set me up to do what? Go self-medicate with substances of abuse. And the other thing to note is that treatment is an ongoing process. It's not 28 days, 90 days, 1 year. The goal is to keep the person engaged in a program of recovery. And this doesn't necessarily mean committing to any one thing in particular, but it's knowing how to manage your feelings and emotions, knowing who to seek out when you feel in terms of crisis, learning to actually go to others when you're in periods of distress. So we encourage people to realize that just because they have walked out the gates of treatment, that the battle that they have to live is still ongoing. And what is recovery? Recovery is that whole process of making lifestyle changes. It goes from everything being somebody else's fault to one being accountable to one's behavior. And it's a process of establishing a healthy pattern of living. And this includes not only nutritionally, but addressing their health issues. You know, I can't tell you how many people who've had some type of medical condition that they basically just haven't attended to because of their substance use. You know, I'll see people who talk about a spot that they've seen on their skin, and I'll say, well, how long has it been there? Maybe 3 years. You know, this is the first time they even thought about as they once again start to get their awareness about them and start being able to understand their own needs and health issues that they start addressing those. And recovery is also ongoing. Okay, I tell you what, I'm gonna hold up here for a second to see if anybody has any questions. I had a couple other slides about medication-assisted treatment, but I wanted to make sure that we covered everything about this before trying to introduce those.
Okay, the floor is open for questions. If you're shy, you can put them in the chat box and our moderator will present those. Well, Dr. Burley, I do have a question.
Okay.
I actually have several, but I'm not going to take up that type of time. I was taking all sorts of notes and I realized I almost had a whole tablet full of questions. But one of the things that I wanted to ask, and we hear the term, I think you hit it. It was just not in the term that I'm accustomed to hearing it. So excuse me, I'm definitely not clinical. So let me say that first. But many times, when you were talking about the addicted brain versus the non-addicted brain, where does what us non-clinical people call functioning alcoholics, where do they fit into that realm of
functioning alcoholic?
And maybe that's not a real term, but
no, it might not be a DSM term, but it's a real world term.
Okay.
And a functioning alcoholic is somebody who hasn't experienced enough of those consequences that it's affected them enough to make changes. Being a functional alcoholic can sometimes be one of the worst things that could happen to you because not having those consequences, you're more prone to develop medical consequences, heart disease, hypertension, diabetes, all these things around you. Those functioning alcoholics may be able to function in their minds themselves, but typically they have issues with their families, their jobs. It might not be enough to make them lose a job. Okay. They might not be the first person to work every day. And they may be more prone to have arguments with family members and not be able to process the things happening around them. You know, we talked a little bit about the frontal cortex in terms of adjusting to things and acting responsibly to what's happening in your life. And what happens is those functioning alcoholics, their way that they look at the world may be somewhat different. It may not actually be based on the reality of what's happening around them. So while they may not have real bad things happening to them, they can still have things happening in their lives that could definitely be improved.
Thank you.
I must have covered everything.
If you have any questions, please add them to the chat box and we will, if you don't want to open your mic, please put it in the chat box because this is some very valuable information. I know I have a few questions myself, but I won't take the time. I'm gonna give that time to you to ask the questions. Dr. Burley, I see none, so we can continue.
Okay. All right. Well, I tell you what, I'm just going to put up a couple of things. Can you hit the next one? Want to talk about risk factors for relapse. We talked about that, stress, isolation, the untreated co-occurring disorders. All right. And
Dr. Burley, there is something we have from the question says, Dr. Burley, will you talk more about the research that supports the use and outcome of Suboxone?
Boy, they are insightful because I am just putting that up right there. That was what I was going to talk about if we had some time left over. And that is the use of medication-assisted treatment.
Okay.
I know this slide is kind of wordy, so I don't like using it all the time. But basically, summing this all up is that medication-assisted treatment with Suboxone, methadone, naltrexone, the goal is harm reduction. As we work with more people who have been in the treatment process, one of the things that used to occur in 12-step meetings in the recovery community was for it to be frowned upon to use substances to deal with their addictions. As we've learned more about it, we've learned that it's not alternating one drug for another, but it's using substances to block that craving. Because once again, we talked about the chemistry of the brain, and blocking different receptors can aid a person in terms of their recovery. We know that the use of a drug like Suboxone is not necessarily a cure-all in its own, that it has to be paired up with other behavioral interventions, which focus on coping with stress, working on self-regulation, helping gaining insight into their needs. That's why one of the things that the state has implemented with the methadone clinics is that methadone clinics are mandated to provide a certain degree of counseling and other interventions to clients. So it's not where they just come in, pick up their drug at the window and go home. Because that's, if you don't address the other issues happening in their lives, they are still prone to relapse, and maybe not on opiates, but on other kinds of substances. But with the explosion of the opioid epidemic, it's become more apparent that we need to do all that we can do to keep people safe. I know, I'll use Dr. Outlaw as an example because she was the only person I know that was around back then. was that at one point, we talk about first responders carrying naltrexone with them now. I'm talking about Narcan with them. At one point, one of the manufacturers of Narcan tried to offer the state 5,000 doses of it, and we couldn't figure out which department it belonged to. So now we've moved it to where we're having health fairs where we're passing it out to people. And we've actually working with pharmaceutical companies and to be able to provide it in some areas as an over-the-counter product is what it's moving to. Because the idea of harm reduction is paramount now. There were over 100,000 drug overdoses last year, and roughly 80,000 of those were related to some kind of opiate drug, which is actually the number of opioid deaths, I think, the last year was twice the number of car crashes. Yeah. Somebody's got a Suboxone question.
There's another question in the chat box, and it says, it's coming, is there any strategy in place to improve the access to patients and also for providers to prescribe, meaning in the context of existing disparities?
Okay, to provide people. Yeah, I think I just mentioned that. The removal of the X waiver is huge in terms of hopefully increasing access. That previously to prescribe Suboxone, you had to take a course of so many hours and then get a special DEA license. But those requirements have been waived in hopes of encouraging people to become prescribers of Suboxone. Because one of the things is that your typical primary care physician doesn't want to load his practice or her practice with substance abusing patients, which was typical to practice that people had X waiver licenses tended to cater to more of a substance abuse population. So the hope is that by removing those requirements, we can improve access by just physicians who just in the course of their normal practice, who may have a patient with a substance abuse issue, can provide them access to Suboxone.
Thank you so much, Dr. Burley, for that just great presentation and amazing Q&A. We truly appreciate you. Here's what I want to do. I want to be a good steward of time as well. So if anyone has any additional questions, can you please send them to Mr. Fleming? And also, Mr. Fleming, we're going to multitask and have you drop the survey in. And I see Dr. Outlaw has turned her camera on. But yes, at this time, we want to be a good steward of time and going to start to adjourn. So Mr. Fleming, I'll turn it back over to you.
Thank you, Dr. Brown. And Dr. Burley, do you have any additional words that you want to say before we wrap up?
I tried to talk as fast as I could and be legible. So try to get it all in. I just want to encourage people to when they encounter these patients, wherever they might, because they are everywhere, from your community to in your practice, and many of them just need somebody to reach out and let them know that help's available. And that's what we're trying to do these days is because I will throw one thing in that we're doing too. We are working more with faith-based organizations. That's a whole nother topic of discussion, is the use of faith-based organizations to help people with treatment needs as well as mental health needs.
Oh, Dr. Burley, there was another question, and I think you just answered it. The question was, are there any new updates and or treatments? But I think what you said was an update.
Yeah, I will throw out something that they're looking at. We talked about the reward pathway, And typically, we've looked at naltrexone as impacting just at the opiate receptors. But now there is additional research looking at it potentially having a pattern of a capability of disrupting some of the sequencing in the reward pathway. So that's one of the things that's actually being looked at currently.
Thank you for that, Dr. Burley. If you have registered for this meeting, you will be receiving your survey via the Zoom link. It'll pop up in your browser later on after the meeting is ended. So please, when you see it, please click on it and do the survey. Are there any additional questions for Dr. Burley this evening? And Dr. Outlaw, would you like to have any closing words?
No, Dr. Burley just proved what I said. He's the man about this addiction medicine. It was wonderful presentation, very informative. Thank you. And I heard you call my name.
We're just checking on you.
Again, thank you so much, Dr. Burley, for that very
It was
informative.
my pleasure to be here. And
Yes, sir.
If anybody has any additional questions, they can feel free to email me. It's howard.burley@tn.gov. It's pretty easy to remember. And also, I think I saw a question about the presentation being available, and we can send that out to anybody that might be interested in it.
Absolutely, and I'll do that. So if there's no additional questions, thank you for attending our lecture for this evening, and we'll be back on August.
In August.
August 2023. See you all soon.
Thank you so much. Y'all have a great evening.
All right. Good night, everyone.
Good night.